Yeah, so there was a huge learning curve, and it all started right after the pandemic. So I like to say it was kind of a blessing and a curse because I feel like it accelerated PTs into the telemedicine space like 10 years, ahead of what it probably would have taken if there was no pandemic. So a huge learning curve because I was used to everybody. I was like known as like the manual therapist in the Chicago area. Like I would mobilize, manipulate, dry needle, pretty much everyone that came into the clinic. I like to say after fellowship, I was crack happy. Just wanted to, manip everybody. But yeah, telehealth or virtual PT almost makes you have to get really good at your soft skills. So active listening is huge. You can't be cutting someone off when they're giving you their background, their subjective history, stuff like that. And then I keep it very, very simple. I like the KISS method. I keep it simple, Steve, I say. So I blend kind of the pain mechanism classification system. So is it nociceptive? Is it nociplastic, or is it peripheral neurogenic? So kind of put one in the, each bucket, or maybe a mixed presentation, whatever the dominant pain driver is probably. I use the yellow flag risk form on every patient now, which a lot of students and stuff that I've mentored, they're like, why do you use this on everyone? Because just from experience, especially these days, everyone has some sort of mental health component to their MSK pain, I would say. So I think I saw this, he was real athletic, real fit, finance guy, seemed to have a great life. And he just wasn't getting better after maybe 3 or 4 visits. And then I gave him the yellow flag risk form and was off the charts. So then we had to do a little bit more dive into like the affective component and some of the other underlying behavior stuff going on. So I like to give that to everyone. And then I feel like that just makes your job so much easier. So, all right, this is strictly nociceptive. With those folks, then I got all my little joint models. So like I got the spine here. I could cut out the disc. It's not about pathoanatomy, but I feel like patients are like, oh, that's cool. So got the spine, and then I got all the extremity joints that move. So especially if you're talking about a directional preference, I think it's cool to be like, all right, we're constantly going this way. Maybe if we stretch back here or here, that's going to, balance things out. I'm like, oh, that makes sense. So yeah, blending MDT, the pain mechanism classification system, and then the SFMA I also used. I've taken the training in that. So that's, if someone's at, typical MDT dysfunction, I like to run them through the SFMA. It's simple. It's not, no system is perfect, but at least it gives you ideas to work on maybe some other areas in terms of like regional interdependence. And then I like the Mulligan self-treatment book. So then I'll teach people self-snags. And then that's the thing. I'll say, hey, you don't need to be going to your chiropractor 3 times a week for 6 months. Like, let me teach you how to self-adjust, whether it's using end-range repeated movements or MWMs. I think I've had really good success with that. And then, just using the Maitland. I think the Maitland approach does a really good job at the subjective. So if you just listen to the patient, spend a lot of time listening to their story, they'll tell you, what does the literature say? Like 80% of what's going on. So while people are I'm just jotting down some notes and, generating some hypotheses, what's going on. And then the buy-in is unreal. If you can get someone to reduce a derangement or perform a self-snag or something, and they're just like, oh, wow, my pain is better, my range of motion is better. So I think all those systems use the, response-based assessment. So I always like to do that, set a baseline, or I like to call it the symptom-provoking functional movement. And then, all right, so you show me this. I'm going to write that down. Let's have you do 30 retractions, extensions, and then let's recheck whatever their baseline was. And then the buy-in, once you do that, I feel like that, bam, like they're sold. And it's so simple. They're like, oh, I can do this at my desk every couple hours. And yeah, absolutely. So it's cool, kind of blending all those approaches. I feel like in PT, we just have such a branding problem, and just everyone's looking for the next best thing. The next, what's the new sexy intervention? Is it needling, cupping, whatever, how it goes. So I like to say experts do, the basics really well. So I feel like it's very bare bones, low tech doing virtual PT, but you can still help a ton of people. And then I can usually tell, during or after the assessment, if they're pain adaptive or if I maybe need to refer them out. So then that's what I'll say. I'm almost like a healthcare navigator for them then. So say, hey, you're located in New York. Let me do a quick Google search with your zip code, and maybe I can find an in-person provider that's an OCS, a fellow, a McKenzie cert, so then we're kind of speaking the same language, and members, patients really appreciate that.